Hey everyone, this is Dr. Vipin Kumar. I am a gynecologist, a lab surgeon, and a reproductologist from India. While working on this paper, I was working in Almaty, a city in Kazakhstan. And presently, I reside in Kuwait and work as a gynecologist here. So before we go into the paper, it's my duty at the same time to give a thanks to the SciTech conferences to help me and give me an opportunity to present in this conference, which really means a lot to me. At the same time, a big sorry, a big apology that I couldn't attend in person because of my personal commitments in the hospital, where I got no leave as such to come there and have a good time in the conference. So apologies for the same again, but hope so this video PowerPoint presentation will try to at least merge into or overcome the absence that I am creating there. So before starting, again, consider my apology in an official manner. So let me start. Okay, so the paper on which I'm going to present is the effect of intra-ovarian injection of platelet-rich plasma to patients with diminished ovarian reserve. It can be also called as a poor ovarian response. So this is a novel concept, right? So before going to this platelet plasma, we know that aging causes a lot of different changes in the physiology of the human body and is associated with increased risk of infertility in females. So over the course of time, ovaries experience a decrease in their follicular quantity and also the quality. And this is what is known as the poor ovarian reserve. And when these women undergo an ART treatment, they doesn't respond to the stimulations of gonadotropins given to them, which in turn is known as poor ovarian response, or DOR or POR. Despite age, so far different laboratory tests and ultrasound investigations have been used really to find out the degrees of ovarian reserve and the response. We have been using now serum luteinizing hormone, follicle stimulating hormone, the anti-Mullerian hormone, also the anti-follicular count, which we look in the ultrasound, and the estradiol levels, right? So now even ovarian biopsies are done to confirm whether they have any potential left to give up the follicles. So far, many treatments have come and gone on the way of rejuvenating these ovaries and making it again into a potential to give follicles. But now, here I am going to discuss about the platelet-rich plasma. You know that it had been used for multiple things. It has been used in many trials for accelerating the healing of acute and chronic wounds, plastic surgeries, tendinopathies, and many other regenerative roles it has. And you know, there was recently a PRP study, that is the platelet-rich plasma therapy, was given to a possible of 17 women who were diagnosed with poor ovarian response. Before that, it was mainly found out in women who had recurrent implantation failures, and they really did a wonderful job. And that was when the obstetricians and the gynecologists thought it may be of a point to give it for cases where there is poor ovarian response. And here, when it was done, it gave a better result. So, but still there the studies are very less and the data is inconclusive, and its insufficiency has led to give out a particular result whether it is effective or not. So this study, we aim to assess the outcome of PRP therapy on the hormonal profile, that is serum LH, FSH, AMH, and to determine the number and quality of oocytes retrieved after the PRP therapy. So rather, we are not focusing on the number of embryos or the quality, we are focusing on whether we are able to get good quality oocytes. That is our primary aim. Okay, so coming to the material and methods. Our study design was a prospective cohort study, obviously followed up the patients. It was done in 3 places. Our center, that is the MIRACLE IVF clinic, it was in Thane, in Almaty, Kazakhstan, and in Tashkent, Uzbekistan. So it is a multi-centric and multinational study, to be very precise, and I'm really proud of it. The study period was for 1 year from 2021 October to September 2022, and we actually included 297 patients who visited our clinic and we diagnosed them, but 163 were excluded based on the exclusion criteria, which I will come on to. And at end we had finally 124 patients who were enrolled for the study. Convenient sampling method was used to take the sample size, and also when we took the patients, they were the patients who were couples with failed IVF and had diminished ovarian reserve, which I will come to, and who belong to the age group of 35 to 45, including 35 and 45. So for defining that, we used the European Society of Human Reproduction and Embryology Working Group convened in Bologna, and they proposed the definition, which was included in ASRM later on, that two of the following criteria has to be present to define this. That is a decreased ovarian reserve, that is advanced maternal age, previous poor ovarian response, and having an abnormal ovarian reserve test, that is AMH less than 1. So this was used to select our sample size. And the exclusion criteria was basically those patients who were lost to follow-up or didn't do their hormonal assessment in time and it was incomplete, and also those patients in which the cause was basically another cause of infertility rather than being a cause of decreased ovarian reserve. Those patients in the first meeting itself or consultation, the doctor excluded the cases. And also those patients who had serology positive were excluded from the study for multiple reasons. And the study population then underwent the PRP therapy after a proper written consent which was obtained. Now, after the patient were enrolled, a recent lab analysis were done for the patients, basically on day 2, or if missed, then on day 3. And as I said earlier, the hormones we included were serum LH, FSH, estradiol, and AMH. It was done on day 2. And a record was obtained from the previous IVF cycle also. As I said, those patients who had failed IVF were included in the study, and what were the number of oocytes which were received, and what was the number of M2 that we know as the good quality oocytes. What were the number were also noted down. Then these patients within the first 7 days of menstruation underwent platelet-rich plasma administration to both the ovaries, using sedation as the anesthesia, basically using sedation, and using a 24 gauge, that is very thin needle. And in places like in Kazakhstan where we couldn't find the needle, we used a spinal needle, long spinal needle. And the procedure was done after obtaining the consent from the patient, as I said earlier, to be very much into the picture. And this helped us avoid the complications also. So after the procedure was done, the patient underwent the stimulation protocol on the second menstruation. What I mean to say is that after the PRP was done on the 7th day, within the 7th day of menstruation, we waited for 2 cycles at least and then called the patient to look for the ultrasound of the day 2. That we waited for the second menstruation, we called the patient back. And this time was given so that the PRP acts onto the follicles and brings the necessary changes. On the second day again, the hormones were repeated to see what is the effect after the PRP. And we repeated the same profile which included the LH, FSH, E2 and AMH. And obviously after the patient underwent stimulation, again we surely note down number of oocytes and number of good quality oocytes, that is the number of M2. So if I summarize what we did, first of all, we prepared the PRP, we separated the platelet-rich plasma after centrifugation, right? We used basically 20 ml of blood sample that is collected from the patient under sterile conditions, and we used basically a T-lab autologous platelet PRP kit. There are multiple PRP kits available, it's better to use that. And after the blood collection, the tubes were centrifuged at 800 to 900 rotations per minute for 8 minutes. And to collect the blood, we used a 16 gauge needle to a 5 ml syringe, put into the tube and washed the buffy coat layer slowly, and then the PRP was collected by rotating the needle tip. Once we take the PRP in our tube, we need to shake it properly for at least 60 seconds. And this PRP needs to be transferred. And we can collect one more test tube. At least you should have at least 4 to 8 ml of PRP. Patient has to be taken under anesthesia, sedation, and a transvaginal probe is used. So the procedure is in transvaginal under the ultrasound guidance, and basically it should be done within 2 hours of the sample preparation. So as I said, the sedation was used, and we use a thin needle, a long needle, and the injection was done underneath the ovarian cortex to the subcortical and ovarian stroma. That is what makes the difference. Actually, multiple studies injects multiple places this injection, and what is found to be most effective is injection was to be done under the ovarian, underneath the ovarian cortex, and basically up to the level of the subcortical area, or what we call this, above that, inside that is the stroma. So sometimes it becomes difficult, especially in case of fibrosis, where there is a lot of difficult. We have to create a plane by dissection and then go for the injection. Sometimes it may become difficult in certain cases. So after the procedure is done, which patient wakes up, patient is given at least 1 hour, 30 to 40 minutes of rest in the hospital, and patient can be sent home. So PRP injection was timed randomly in women who were amenorrheic, while in women, basically they don't have menses, then we just did it randomly. And for those women who had menses, oligomenorrhea or menorrhea, it was done on the 7th day. We were specified on day 7. It can be done within the 7 days, but we did it for the 7th day. And the basal antral follicle count was done, antral hormone level was done in the second day too, as I said, and also the FSH level. And also we repeated the day on the day of PRP also, to just see on the day of PRP what is the level, basically the AMH. The variations that we found in AMH, the inter-assay coefficient variation was less than 0.05 for AMH, and for FSH it was less than 5. So after PRP injection, both amenorrheic and oligomenorrheic women were managed expectantly for 6 weeks. As I said, for at least 2 menstruations, we were not doing anything. Those who did not have menstrual bleeding for 6 months, obviously we tested for pregnancy, and when negative, we gave withdrawal bleeding for them. What we gave 2 mg estradiol valrate for 15 days, followed by 0.5 milligram of norgestrel, which is progesterone, for 5 days, and this led to the withdrawal bleeding, and then we called the patient and went for the ultrasound on day 2 or day 3. And the same strategy was repeated if the menstruation didn't come again and it was delayed. On the 2nd to 4th day of the second menstrual cycle, after the PRP procedure, AFC and serum AMH and FSH levels were reassessed, as I said earlier. And if antral follicles were present after this PRP, we started on the controlled ovarian hyperstimulation for this patient. And if antral follicles were absent, we again followed up till how much time? At least for 6 months. Every month, again doing a scan to see if there is any availability of follicles, and underwent the COH, that is the control ovarian stimulation, when or if they developed any antral follicles. And following each assessment, patients who did not develop antral follicles were treated with estrogen and progesterone, as I said earlier, for 15 days. And this was done so that we can easily schedule the patient, and we can control the cycle progress also. Now, what we call it is as a positive response to the PRP therapy which we had. How do we call it as, yeah, the result was positive or significant? In the conduct was when at least one antral follicle was seen in the USG in women without any antral follicles earlier, okay, or there was an increase in antral follicle compared to the baseline, means there were some follicles earlier and now there is an increase, or there was an increase in AMH, or even when there was a decrease in serum FSH, we consider it as a positive result. So women who were found to have at least one antral follicle were started on the ovarian stimulation, as I said earlier. And in case an increase in AMH or decrease in FS was there, but there were no antral follicles compared to the basal, then the stimulation was not started. Control ovarian hyperstimulation and the IVF procedure which we followed for these patients post PRP was as a normal patient. That is, we started the stimulation with gonadotropins on the day 2 or day 3. Normally it was based on the BMI, the age, but basically we used 300 recombinant FSH or 300 international units of HMG based on the FSH LH levels, and followed the patients with serial ultrasounds, estradiol level. Monitoring was done with estradiol and the progesterone when required, and DBS as we do always. And when the dominant follicle reached 14 mm, we gave the antagonist, that is the cetreotide. So basically we followed an antagonist cycle. And the trigger was given when the leading follicle was 18 mm, and the trigger which you use were recombinant HCG 250 micrograms, so that there is follicular maturation. Now coming to the most important part, and that is the analysis. How we went ahead with the statistics, thanks to my statistician who helped me out. Basically it was my wife who helped me out in this, the statistics part, and she's another author of this paper. So we used the Shapiro-Wilk test for the distribution of data, and we used Wilcoxon text to compare pre and post treatment values. Obviously, we used logistic regression to estimate the odds ratio of having at least one mature oocyte or at least one cleavage stage embryo in percentile categories. And also, we used stratified analysis was also performed to investigate the odd ratio among the women in different age groups. We use SPSS for analyzing all the data. So obviously, as usual, p-value of less than 0.055 was considered significant in our study. So coming to the important part, that is the results. So we carried out the inclusion criteria for the patients, selected the patients, that is 124 patients were selected after carrying out meeting all the inclusion criteria and doing the exclusions. And then these patients were undergoing platelet-rich plasma therapy, as I explained earlier. We waited for 6 weeks for the action to happen, and then we did the ultrasound, did the hormonal markers, and then went ahead if there was an increase in the AFC count, or if there was at least one follicle in people who didn't have any follicles. So this was the baseline when we started. We ahead with antagonist cycle for these patients, and this slide is important because it shows the demography. Demography is a very important factor whenever the study is multinational and multiple ethnic groups are involved. Here we had people from India, we had people from Kazakhstan, we had people from Uzbekistan. And therefore, it was very important for us to highlight in the paper what is the baseline characteristics if we average them out. So the first thing, the age, the median age of our study group was 43, ranging between 41 to 45, and the body mass index, the average was 26, and 8% of our patients were smokers, comparatively less but not less. 71 patients were nullipara. As far as previous miscarriages are concerned, because they are important factors having their own effect on the infertility and the IVF result. So 87% of patients never had any miscarriage, 10% were having at least one abortions prior, miscarriage prior, and 2 to 3% had recurrent miscarriages. As far as hormonal levels are concerned, the baseline AMH was around 0.73, important, ranging between 0.5 to 0.8, and the baseline day 3 FSH level was around 15. And as far as antral follicle count are concerned, it was between 5 to 7 or median 6. So okay, we went ahead with the sample population, and this is the result we had. This is a table which compares the ovarian reserve parameters pre and post treatment. Just put your eyes onto the last column, that is the p-value. Just see how significant it is. There is nothing to be hidden here, right? It is such a proven study which shows the result so significantly improved. See the AMH level getting improved from 0.7 to 1, the FSH level improving from 14 to 10. There is a drastic decrease, and which really matters, as the p-value is 0.001. And see the follicular count, it is 6 pre-treatment and it changes to 9 after the treatment with platelet-rich plasma. So the results were very much encouraging after we went ahead with the study. And what matters most is it was conducted in 3 different places, done by 3 different group of people who had different approach to having platelet-rich plasma therapy. Still, anyway, we followed the same method. There were so many biases, error that can come when it is done in 3 different centers, but still the result was encouraging. So women treated with PRP had significant improvement in biochemical and ultrasound markers of ovarian reserve. You can see the AMH levels were on average 72% higher following the PRP. So this is the most important part of the study, the final result. This table basically shows the outcome which we had, the primary outcome, that is the number of oocytes and M2 collected from this. So if you see this table, it is a constituent form of what we achieved in this whole study. So out of the 124 patients who underwent PRP therapy and followed by which they underwent IVF stimulation in multiple stages, some after 6 weeks, some after 2 months, some after 3 months, and within the 6 months period. So the number of oocytes collected from them after this therapy were on average 6, at least 3 to maximum 11. It's wonderful, right? And the number of fertilized oocytes were 5. Just see the percentage. The fertilization rate being 0.7. As far as the embryo quality is concerned, though it was my secondary outcome, 79 as top and medium quality embryos. So just realize the good quality of embryos and good quality of oocytes which we received after the PRP therapy. So if you ask me to summarize my results, or our results to be very frank, out of the 124 patients or women who underwent IVF ICSI after the PRP treatment, they yielded on average 1.5 times the number of oocytes collected, right? And the quality of oocytes, that is M2, retrieved after the PRP were also significantly higher. So this is a study to be brought into the picture. So now comes the part where actually we need to discuss this study. How do we describe this study? Based on the results, based on the way conduct, based on the materials and methods used, based on its being multicentric. We followed 124 extremely poor prognosis patients between this age group of 35 to 45 with an objective hormonal or IVF outcome related effects of PRP after comparing IVF cycle outcome before and after the PRP. I just want to include this point in between this because it's important. 2 of these patients who were 40 years or older who underwent this PRP therapy actually conceived and delivered viable offspring, that too a term baby. So keeping that aside, we also observed a statistically significant increase in the antral follicle count as I showed in the result. So this study must also be viewed as only one of 3 currently ongoing registered PRP studies at our center, with the 2 of others having more rigid patient selections. So this is a diverse population since the cohort study with patients selected with a very clear way to select the patient, and that too from 3 different places. And these were the patients who had no other option rather than going for an oocyte donation, rather than having this alternative of a PRP therapy. In this study, we used, as I said, we used a very thin needle for PRP infusion to minimize the mechanical effects, right? And this in turn have shown by others to activate the dormant follicles. So using this thin needle and having 7 to 12 punctures per ovary, it causes a lesser mechanical disruption. Therefore, this study in several aspects is different from other studies having different PRP outcomes. Therefore, our study having such a positive result should not come as a surprise. Therefore, at least of this moment, should not be interpreted as a rejection of all the PRP treatment in women with decreased ovarian reserve and poor ovarian response. So this study, however, I will say unsurprisingly, offers a preliminary part, and like most fertility treatment, any success of this treatment needs to be based on depending on the patient's age, the younger patient as compared to the older patients. When I say that, I need to compare my study with the studies which are available in this study period. As far as Milo et al. Study is considered, where he compared 39 patients who chose PRP before IVF to 37 patients who didn't choose PRP. It was a non-randomized trial, prospective study like ours. Ours, in this study, they have no significant difference in the AMH. Unlike our study, there was no difference in the AMH. So therefore, it is not only the PRP installation that matters, it is also matters on the day, the time, how and why was it done. So however, they reported that in post-PRP cycle, there was significant improvement in the oocytes yield. So hormonal levels may not be different, but they showed, as our study, that the number of oocytes were improved, and this also led to the improvement of the embryo quality. In another study by Sills et al., it was again a prospective non-randomized study. He did a trial with 182 patients who received PRP after a previous failed IVF cycle like ours. These investigators did find a statistically significant improvement in AMH in women, both under and over the age group of 42, as in our case. And they showed that the peak response was 4 weeks after the PRP. There was a recent cohort study of more than 300 women, but young women with decreased ovarian reserve found increased follicle count also and AMH level also following the PRP treatment. Also, they have shown that 23 women conceived spontaneously. In our study also, we are waiting for the others to get the positive pregnancy result and then add to the study. That's why I said the study is still ongoing. So there are multiple aspects. So it's multiple aspects on which the study depends. So the studies published so far are difficult to compare, right? Because of the technical differences. That's what I'm trying to say. How the PRP was prepared, differences in the PRP volume injected into the ovaries, and the different locations of injections. It was into the stroma, in the subcortical area, into the cortex. That matters. So for example, some early studies used activated PRP, like in the Sills et al. Study, it was activated PRP. While we chose not to use activated PRP because many studies have shown medical fields other than the PRP study also, where activation did not improve any result. And because of the experimental nature of the study, we also try to minimize the volume of injected PRP into the ovary and therefore used a very small amount, that is 0.4 to 0.5 ml, that reported in most earlier studies. Also, I would like to say the other studies inject intramedullary into the ovary, expecting diffusion into the subcortical layers, but we directly introduced into the subcortical area by causing multiple subcapsular injections, which we found to be more appropriate. So, as I wrap up, 3 things that comes in my mind is this study has a relevance. This study revealed that the injection of PRP into human ovaries is safe. First of all, we didn't have any complications. Again, I would like to say it improves the ovarian reserve markers and also the anterofollicular count. We saw the improvement right in the AMH and FSH level. There was a 72% increase in the AMH level. There was a drastic decrease in the FSH level. Also, there was improvement in the oocyte quality attained. But, a big but, further studies will always be welcomed, and we need to evaluate more on the impact of PRP, basically on the next aspect that we got the oocytes, now what is the effect on the embryos, how is going to have the effect on the getting pregnancies. So more studies have to be done to prove more into this context. So this is what this study aims at. Thank you so much for hearing this presentation. Thank you again, SciTech conferences, to give me this opportunity to present this. And again, the same time, I lend my apologies. So all of you have a great conference ahead, and I hope the 34th summit reaches 100th summit of the Women Health and Nursing. So thank you so much. Have a good day.